This talk is on psychological therapies for older people. What works for older people, the type of people who get referred, and some misconceptions that are actually in healthcare when it comes to older adults regarding psychological therapies. Right. Older people do generally respond well to psychological therapy. Response rates are good, just as good as those as younger adults. They especially work really well in IAP services, found much higher recovery rates for those over 65, and they are more likely to complete the treatment than in other age groups. Generally, the psychological therapies which work really well with older adults are things like cognitive behavioural therapy, reminiscence therapy, are generally considered to be the most successful with older adults, as there is also specific evidence to say that CAT or cognitive. Right, who gets referred? Clinical levels of mental health distress are present in 40% of over 65s who attend their GPs, 50% on inpatient wards in general hospitals, and 60% of those in residential care homes. This was according to the National Mental Health Development Unit 2010 piece of work that they did. IAP, in its first year in 2008/9, just 4% of patients were over 64, and this had only increased to 6.6% by 2014. Their expected representation was 25%. Older adults are not accessing psychological therapies in the numbers expected. A national study of older people's secondary mental health services by the Healthcare Commission 2009 found that older adults receive particularly poor access to psychological therapies, alcohol services and crisis services. An inquiry by Age Concern and the Mental Health Foundation 2006 identified two forms of age discrimination in mental health services: direct or explicit unequal treatment, and indirect. Indirect age discrimination is apparently neutral practice that disadvantages people of a certain age, for example, designing services around needs of younger adults without taking older people's needs into account. There are several barriers for why this tends to happen. One of the main ones is therapeutic nihilism. Basically, there's still a lot of thinking within the healthcare community, etc., that depression is an inevitable consequence of aging. Also, false belief that older people do not engage with or benefit from therapy. Also, groups are insensitive or intimidatory when it comes to sensory loss. Clinical-based services, there's difficulties with mobility, transport, poor physical health. One of the main ones I would really like to point out is lack of staff confidence, because not everybody is able or feel capable and have the ability to work with older adults. Another false belief: older people don't want therapy. Some people, it's even been said that I've heard people saying she's happy being miserable. One story I actually do remember from somebody who I used to see was a lady in her late 80s who'd, after a fall, started having flashbacks from being buried during World War II when they were a child, and they went to see their GP to express their concerns, and it was making them really depressed and quite down. And she was basically told by her GP that it was over 70 years ago when this happened, surely you're over it by now, which is not really very helpful at all, is it, when it comes to older adults? There is one thing I would like to explain to people and there's a little exercise which follows. It's called the cohort effect. Basically, your cohort is the group of people of your own age or class of. Beliefs you grew up with, e.g. homosexuality considered a psychiatric illness, up until the 1970s. The health and education services you had access to during your life. Working class people had very poor access to higher education until very recently. Dyslexia and autistic spectrum were not recognised. Also, major events that happened during your life, either a war or recession or any major event that would possibly have happened. Major cultural shifts you were influenced by. A common example of that is the swinging 60s. The technology you are familiar with. Opportunities you have had, e.g. at work. The ideas you have about personal relationships and social behaviour, how you feel, what you feel comfortable with, manners, dress code, tattoos, etc. Things along that line. Specific exposure risk to things like radiation or asbestos. The impact of current or political situation, where this is age specific. The impact of current cultural beliefs around aging. The impact of our own beliefs around aging and other personal characteristics. Now I'm going to give you a little exercise to do, which would be more ideal if there was one or two of you to actually do this. The exercise is a series of little questions which you can ask each other to get some interaction to see how the cohort effect actually works. It would be more ideal if the other person is either younger or older than yourself in a different generation, for example. Questions are: how old are you? What was the socio-economic environment you grew up in? Did you have your own bedroom, toys, books, space? What view of parenting did your parents have? What did your parents expect you to do with your life? What major events or changes happened in the UK during your childhood, or in your own particular country of origin? What was the first record or CD or iTunes you bought? Can you remember your first kiss? Or the first significant one? Last question: how do you contact those you love? Now if you give yourself 5-10 minutes between two of you to actually complete that, you will hopefully see how the cohort effect actually works. There are many challenges for today's older people. There are specific cohort risks, for example falls, depression and generalized anxiety, completed suicide, dementia, chronic ill health like arthritis, diabetes, acute ill health like cancer, flu, bronchitis, poor mobility, war trauma, alcohol and drug dependency, fear of falling, death or crime, and ageism. As people get older, certain mental health needs become more common. Mental health problems developing in later life involve a range of conditions, including cognitive disorders, mood disorders, and psychosis. Multimorbidity of both physical and mental health conditions, cognitive disorder or dementia. Problems related to being at a later point in life cycle that include psychological and social difficulties and lifestyle. Also physical frailty. So what could be considered good mental health for today's older people? Good mental health in older people is supported by having a role and purpose in life, having good social networks, enjoying an adequate income, living in a supportive environment. This can and does involve being able to adapt to physical changes, independence and risk-taking, fulfilling desires and personal objectives, being engaged in relationships.
Thank you, Mark, for a really interesting talk. Just want to remind our listeners that there is a part 2, so it's important to listen to that recording as well. Thank you.